Sharing to live stream. Okay, we are live. Hi, everyone. This is Sophia again. Good morning. Thank you all for attending this session today. Today we have the pleasure of hosting Dr. John Paro, a plastic and reconstructive surgeon. As always, please remember that the Google form will be posted in the comments and in our Instagram bio at the end. So you can all fill that out to get credit for your attendance today. With that being said, Dr. Paro, you can get started whenever you are ready.
Okay, perfect. Hey, everyone. Sophia, thank you for the introduction. My name is John Paro. I am a plastic and reconstructive surgeon, and was kind of honored to get asked to share a little bit about the specialty. And I understand that there's a pretty broad range of people that tune into these, anywhere from high school students to pre-med students and various ranges of experience. So I figured we would do a couple of things. One is just sort of describe this specialty, which I don't think I saw on the kind of list of people that have shadowed or done hosting so far, and just talk a little bit about why I like it. You can see from the title slide that I'm not biased at all about how I feel about my specialty. And then we could just talk a little bit about like what is involved with it and some of the things that you may not know a plastic surgeon does, a little bit about training, how to get there, what the options are within plastic surgery, and we'll go through some cases too. It was kind of hard to pick just a handful of them because I think that it's again, a pretty broad field, and the cases are all very interesting. My wife, who is a pediatric cardiologist, likes to make fun of us that our conferences and presentations are basically just show and tell, because they kind of are. They're like, hey, look what I did. And that's okay. That's why I like it. So anyway, plastic and reconstructive surgery. And I figured in the beginning, just a tiny bit of shameless self-promotion and kind of way of background, just so people know, because I always get asked to put this kind of stuff into talks. I went to medical school at University of Chicago. That's where I met my wife, who graduated with me at the same class. And then we went out to training at Stanford. So I did my plastics program there. She did pediatrics and then pediatric cardiology. And now we both actually work for a kind of multi-specialty physician group in the Bay Area of California called the Palo Alto Medical Foundation. And a little bit teeny bit more in terms of shameless self-promotion, just to get out of the way. I have like a very kind of minor, mostly non-surgical presence on Instagram if anyone wants to reach out. And my wife and I started a podcast called Reconciling Medicine, which the whole point of it was just to show that medicine is simultaneously very hard, but the greatest thing that we've ever done. And so we wanted to give kind of our view about why we love it despite all of the challenges. And we kind of walk through the whole journey from deciding how you want to do it to getting through every single stage. There's a bunch of episodes. There's a specific one on why plastic surgery. She has one on why pediatric cardiology. And I think we're up to like 40 episodes or so. So anyway, it's really targeted towards a lot of the same people that might be tuning in here. So if you are interested in that after, being stuck with me for an hour and want to hear more, then you can find that on any place where podcasts are. Someone asked, where did you do your undergrad? I went to undergrad at Dartmouth, and Sophia, who is hosting this, is a Dartmouth student as well. So that was kind of a fun surprise this morning. Grew up in Chicago and then kind of went East Coast for school, back to Chicago for med school, West Coast for training, and then we now stayed in California because we love it there. During med school and during residency, I did a bunch of music stuff, and I kind of tried to do almost like a schoolhouse rock, but for medical stuff. And so there's a lot of songs about cranial nerves and like pelvis anatomy and all sorts of other stuff. And you can find that on Spotify and Apple Music and stuff too. So I don't know. I figured this is the crowd that might appreciate that, which is why I brought it up. It's very important to take pictures of you and your wife in similar looking scrubs walking candidly through fields in the background. That's a very important part of medicine. But the path to plastic surgery, this is an actual picture from residency when we decided that it was a pretty reasonable idea to try and reproduce at that time, and that's my son. For any budding pediatricians in the audience, don't worry. A kid sleeping on your chest with you asleep with no one else in the room is dangerous, but my wife was there, and she knew that sometimes after a long shift, if I was cuddling, that I would fall asleep, but she was there to make sure that everything was safe, so don't worry. So plastic surgery. 4 years of college, There are 4 and sometimes 5 years of medical school. So plastic surgery is one of the more competitive residency programs to get into. And for that reason, many students and applicants opt to do an additional year during medical school to do research, to try to make their application more competitive. I did not do that. I'm not sure if I was doing things now, whether I would feel compelled to or not, but that is a thing that more and more people are doing. And then the residency program itself, mine was 6 years, although it is sometimes 7. Stanford actually changed to a 7th year while I was in the middle of it. So I graduated in 6, but by the time I was leaving, the incoming classes were committed to 7 years, and with a year of research in between. I have mixed feelings on that because not everyone that does training programs, even in academic places like Stanford, wants to do academic medicine. And so I was fortunate that I didn't have to do that extra year, because a year is a long time. So, but it's important to know that there are some programs that make it a 7-year program now. There are still the traditional ways of getting a plastics residency, where you do general surgery first, and then you can do a plastic surgery fellowship, which is typically 2, sometimes 3 years. Those programs are becoming less and less common. So it's typically an integrated approach now, where you apply directly out of medical school. And then after all of that, many people opt to do an additional 1-year kind of subspecialty fellowship within plastic surgery. And we'll talk about what some of those are. I did not do that. I felt like I got a pretty broad education from Stanford, and was able to do a lot of the things that I wanted to do. So I did not feel the need to go and do an additional year of training. But one thing you'll learn as you get into this is that you could continue to train forever. And we're constantly learning, no matter where you are, even when you're in practice. But you could be a trainee for as long as you want. But at some point, you just got to cut the cord and start practicing. But that was kind of my route. So 4 years college, 4 years med school, 6-year residency, and then right into practice. I like this photo because this is what a lot of people think of plastic surgery, right? Is like, you look kind of like a human, but kind of a fake version of a human. And that is not the goal of what I do. And there are some people that really want that kind of done up look. It's almost like a status symbol. That's not the type of plastic surgery I do. And I really think that looks silly. And I think it's also very interesting that most people think of plastic surgery and the kind of plastic and sort of that fake and synthetic look, probably because of the name, but the name plastic surgery actually comes from Greek. The word plastikos means to shape or to mold. And the majority of what I do actually is more in kind of the reconstructive aspect, and improving shape and form, and restoring form and function to the patient that's in my office. And we'll talk kind of again about some of the different things that we do in the field. So one of the reasons that I love it personally is that it's a unique specialty in that I operate on every single body part, and I mean every single body part. Whereas a lot of places, general surgeon is kind of intestinal for the most part, and a urologist has an organ and a couple of body parts, and ENT does, and OBGYN does, and orthopedics mostly bones, and we kind of operate head to toe. I take things out of the head, and I take things out of the toe, and everywhere in between. And my patients are of all ages. So I see little infants with kind of ear deformities that I can place little shaping devices on to correct certain things so they won't need surgery later. So I see teeny little babies in my office, and I see 100-year-olds with skin cancer that need help. So, and every age in between, which is very fun. And what I sort of describe it as, especially the reconstructive side, is like surgical problem solving. They're kind of like riddles, where in your training you learn anatomy and you learn surgical technique, and then you sort of use those to create a solution for whatever you are seeing that day in your office. So every case can be a little bit different, and for me that was really fun. There's sort of a creative aspect to it. I think I kind of knew early on that if I was just doing the same thing over and over again, like, taking out a gallbladder, or you have cancer of the colon, so you take out the colon, and there's no doubt I am not downplaying that at all. But just for me personally, I figured that would eventually grow a little tiring of doing the similar things over and over again. So I really like the creativity aspect of it, and the fact that it can be an incredibly inventive field. So there have been, surgeons pushing the envelope of boundaries of what you can do surgically since So it's really back in the thousands and thousands of years ago. And this picture here is a famous Italian surgeon and anatomist called Tagliacozzi, and he created this thing that's still called the Tagliacozzi flap. And back before syphilis was treatable, it used to affect a lot of places of the body, particularly the nose. It would sort of eat up the cartilage of the nose and sometimes create these open sores. And it'd be a very obvious sign that you had syphilis, and it was very embarrassing for people. And so he didn't really know how to, there wasn't surgical techniques like skin grafts and certain other things. And these were big enough holes that you couldn't just like stitch things back together. So he created this flap where he could borrow skin from somewhere else that had some extra skin available. And so he created a flap where you would use like your arm skin, lift it up, attach that to the nose. And he learned that if you attach that to the nose for a couple of weeks, and then you cut it off from the source, it survives on the nose. It kind of grows new blood vessels. And so this crazy contraption that he devised was the device that people would kind of walk around with. Normally they'd be kind of secluded in their house, but they would keep that there so that they couldn't accidentally pull it off of their. Now, and this is just crazy, wild stuff. And that seems absurd, but that sort of helped push the field forward in terms of we can borrow pieces of tissue from other places to reconstruct defects in other parts of the body. And that kind of logo, or that design is actually the logo of one of the plastic surgery societies, which I think is really cool. But that continues today. There was a big boom in reconstructive surgery actually after both world wars, because unfortunately there was a lot of trauma to deal with. And so they started advancing even more the prospect of like bringing in blocks of tissue to areas that were kind of destroyed by gunfire or other blasts. And they started creating like, oh, we can do blocks of tissue from this place and bring them over here. And still today, plastic surgeons are very involved in things like transplant surgery. You've probably read in the news about face transplants. There you can do hand and forearm, partial arm transplants. And plastic surgeons are very involved in all of that. So I think it's just very inventive, it's creative, and it's one of the broadest fields surgically that you can kind of be involved with. So this, I won't spend a whole ton of time on this, but this is something that we get taught about a lot in terms of surgical problems, especially when there's like a hole to fill. And that hole can be from trauma, it can be from a cancer, but then you're like, how do I fix this? And they talk about the reconstructive ladder and how you're supposed to kind of start at the lowest rung and then you move up only when it's kind of necessary. And so I won't go into crazy detail about all of these, but the bottom rung is what's called secondary intention. Basically, you've got a wound and you let it heal. So if you scrape your knee, you know that you can just let it heal. You don't need to put stitches because it's not necessary. You don't need to stick your knee to like your nose so that it heals like Tagliacozzi. You don't need crazy skin grafts. You just do this thing that's going to be the easiest. So that's what secondary intention means. Primary intention is you actually sew things together. Delayed primary intention is like, oh, that looked kind of nasty. We'll let it heal for a little bit, make sure there's no infection, and then we close it together later. So kind of getting increasingly complicated. And there's skin grafts. You're like, okay, I can't heal it, so maybe we can just take a little piece of skin, put it on. Tissue expansion is a little bit more complicated, but it's where you can stretch out nearby skin and rotate it in. Local tissue transfer means like kind of, if let's say you've got like a big hole in the cheek, but you've got pinchable stuff here, you can like bring the cheek skin up, rotate it a little bit. So it's like local transfer of tissue nearby to fill a hole. Distant tissue transfer, that flap was actually a good example of that. So you're taking tissue from far away, but that's still attached to its own blood supply and bringing it into the hole to fill. And then there's free tissue transfer, which we'll talk about in a little bit. That becomes increasingly common and increasingly utilized these days, where you can take a whole block of tissue on its own blood supply, take it off, bring it anywhere and hook it up under a microscope, essentially as a auto transplant, like a transplant of the person's own tissues to somewhere else. And that's actually, it sounds crazy, but we do that all the time. And we'll talk about some examples down the road. So again, a super wide ranging specialty. I think it's awesome. I listed here what the main 1 year extra fellowships are after you're doing your plastic surgery residency. So like I said, I didn't feel the need to do any of these because I could do the bread and butter of all of them in my practice, and I was happy with that. But if you want to kind of just do one of these, or particularly if you want to have a job in an academic center specializing in one of these, then you often do have to do that extra year of specialty fellowship after your residency program. And the main ones are cosmetic surgery. It's pretty obvious what that is. Craniofacial surgery, we'll talk about that in a second. Hand surgery, microsurgery, and burn surgery. And they're all very popular. I'd say the most popular ones in my program were microsurgery and hand surgery, probably because they're the two coolest in terms of just what you can do. The anatomy is amazing. Craniofacial surgery is also very, very cool. It's just there's not many of them. And the biggest reason to go into that is if you want to do cleft, like lip and palate care in the United States, but there are not a ton of jobs available with that specialty. And so there's a lot of people that apply for a lot of fellowships, and there's like maybe 50 to 60 fellowship spots a year and maybe 1 or 2 job openings a year. So it's you got to really want to do that. If that's kind of your goal. I did a little bit of all of, I do a little bit of all these things in my practice, and I didn't want to do the most sort of complex and erudite of all of those things. And so I felt confident with my training afterwards and didn't then go on to do an extra year of that fellowship. So we're going to go through a little bit of these and kind of talk about what's involved in all of them. Cosmetic surgery, again, is what we're going to spend the least amount of time talking about, just because it's kind of what you know the most of already. And you can scroll through anyone's social media or websites and find plenty of examples of before and after photos. That's all over the place. And so you kind of get a sense of that. And when I went into medical school, I actually had plastic surgery wasn't anywhere on my mind, because this wasn't the thing that I was initially drawn to, the cosmetic aspect. I enjoy it now. It's probably about 25-30% of my practice is cosmetics. And I enjoy it because in the right patient, it's just like a happiness subset of my practice. Like, it just makes people happy. And we showed that picture of the plastic duck earlier. And again, that's not the goal, right? I want people to just feel like happy and confident and just a little bit refreshed in whatever they're going for. But the main kind of groups of cosmetic surgery that I see, so there's a lot of breast surgery. You can do anything to a breast. You can make them bigger, you can make them smaller, you can make it perkier, you can do, and that all kind of gets done based on what is desired by that patient. For cosmetic surgery of the body, there's things like liposuction. There's other body contouring things like tummy tucks, which people have heard about. Essentially, liposuction can remove fat and does a teeny bit of skin tightening. And then other kind of surgical procedures for body contouring removes skin excess, the most common being in the lower tummy. That happens after either significant weight changes and often just with pregnancy. If you stretch things out from twins, for example, the body rarely has the ability to sort of shrink wrap back up, and I can help with that. After losing massive amounts of weight, you sometimes have that kind of really loose skin everywhere. So all around the chest and the arms and the thighs and the lower tummy. And so I do a body contouring after massive weight loss as well. There's cosmetic surgery of the face. So there's blepharoplasties, which is eyelid lifts of upper and lower eyelids. Facelift and neck lifts. There's rhinoplasties, which is surgery of the nose to improve the appearance there. And then there's an increasingly common kind of subset of it with things called injectables, things like Botox and fillers. Botox is a thing that paralyzes muscle. So the muscles of the face, that when they move so much, they create kind of permanent wrinkles or lines. Botox, when done well, just subtly changes that so that you don't get permanent lines down the road. And so Botox and even filler, when done well, no one would know that you have it. It's just a nice little refresh. Actually, I would argue that if it wasn't so expensive, that everyone starting at around like late 20s, early 30s should have Botox every 6 months, because then you would never have those permanent wrinkles down the road. Let me see a question here. Do you ever feel uncomfortable or disappointed that someone wants to change themselves so much? And how do you deal with patients with body dysmorphia? Great question. When you get into the cosmetic surgery realm, you definitely are going to see people that have expectations that are either unreasonable or that their perception of their deformity, right? And deformity is such an odd word to use when you're talking about cosmetics, but that their perception, their degree of severity of their problem is way out of line with the actual degree of their issue. And that's a very big red flag. A common thing is like the actor or actress that has the teeniest little bump on their nose and is convinced that that's why they're not getting any movie roles, and they want you to fix that and all these things. And that's a real thing that happens. And I'm probably shielded from that a little bit because most of my cosmetic surgery patients are either patients that I've done reconstructive surgery on before, or are part of our medical group, go to our primary care doctors and are just kind of looking for refreshes. So I have a lot of people and they're like, 60s who just want to, their face to look a little bit refreshed. Or I have, young moms that have had kids and their kids are wonderful. They love them so much, but the kids leave a serious, set of mementos on the female body sometimes after breastfeeding and after carrying pregnancies and things like that. And they just want a refresh. And that's kind of, so I don't see that quite as much. But I see it occasionally, and I sort of talk with them. If I think that their either expectations are unreasonable or that their perception of the problem, I spend actually a lot of time with those patients to sort of say what surgery can do, what it can accomplish, the downsides to doing things too much. And I often say, no, I will often say that I am not the surgeon for you and I will lose business because of it. But if I get that sort of spidey sense that this is not going to go well, I have long talks with the patient, even though that is not a good business decision, right? It takes up a lot of time. You're not going to do surgery, but you try to have that conversation with them because it's important. Like it's me being a bad businessman, but me being a good doctor. So, and then do you ever have parents ask for cosmetic surgery on their children? Pretty rarely. I see a lot of kids for like cuts if they bump into something, they have a cut on their forehead. Sometimes I'll sew it up if I'm in clinic. Sometimes I've had it sewn up, but they want a scar check. They'll often ask me about like how to make the scar look as good as possible and that kind of stuff. And or can you do a scar revision? And for those, I'll always say, hey, do it if the kid at some point is bothered by it, right? Because then there's going to be buy-in, they're going to want it. And if they're 6 and they got a little scar on their neck from a fall and they don't care about it, this isn't the time to try and do that. So not really. The only time I've done cosmetic surgery on younger kids, like really anyone under 18, is for really, really what's called prominent ears, where they stick forward really far. Sometimes I'll do that, but again, only if the patient is bothered by it. We do a part of our certification process to become a board certified plastic surgeon is you are in practice for about a year and you submit all your cases, and they pick a couple of them that you have to defend in person to this big group of like seasoned plastic surgeons. And there are a bunch of unknown cases that you have to they show you a picture and then you have to walk through what you would do. And one of mine was a young kid with significant prominent ears, and you sort of walk through what you see, what you would recommend surgically, how you would do the surgery, and then they can take you on all sorts of stuff. They can take you through surgical complications, they can take you through like ethical issues. And the one for me was it's the day of surgery, and on the as you're going back to surgery, the kid is screaming, "I don't want this! I don't want this!" And I told him that I would cancel the case, that even though it is, he's not the one signing consent, the parents are, the kid still has to be bothered by his ears and want the surgery. So that was at least my approach to that situation on that kind of oral examination case. Another fellowship that you can do. So a little bit about cosmetic surgery. Again, most people kind of know the details of that, so I'm not going to spend a whole ton on that. I will try and make some time for Q&A at the end so we can, if there are more questions specifically about that, we can talk about it. There is also burn surgery. So most people don't realize that a lot of burn units in the country are actually run by plastic surgeons, not just they'll come in and do some reconstructive stuff. They actually run and manage all of the burn patients. And at Stanford, we spent 4 months as the burn resident. And if any burn happened in the Bay Area, it came to the Santa Clara Valley Burn Unit, and you were pretty much in charge of them. And I had never known so much about all of my patients or have ever been so tired in my life. That picture of my son asleep on my chest was actually from that rotation. You're basically on call, you're on home call, but anytime a burn it comes into the ER, you come in and you admit them. And anywhere from small burns, of the face that just need special wound care, to full 50 to 60% total body surface area burns that you think they're going to die. And so it's a lot of ICU management actually. And so that's part of that fellowship is critical care aspect. And then it's a lot of kind of challenging reconstructive issues that pop up with burn patients. So things like scar contractures. A lot of times if things heal, but they get tight. So big burns in the neck, for example, with time can sometimes contract, meaning pull inwards, and then you can pull across joints and make it hard to like extend your neck. And there's all sorts of soft tissue rearranging procedures and extra grafts and other things that you can use to manage that type of stuff. And then there's a lot of skin grafting. And what a skin graft means is you're taking a partial thickness piece of skin from somewhere else, leaving enough of that skin behind so it can heal itself, but taking enough so that it can heal the place that needs it. And so that's a very common thing for those big total body surface area burns. Won't spend a lot of time on that, but that's one fellowship that you can do after plastic surgery. Craniofacial surgery, we talked a little bit about it. What are some of the things that are involved with that? So facial fractures, people break the bones in their face, and there's lots of bones in the face. And so that's done by a couple of different types of surgeons do those. Plastic surgeons are one of them. Sometimes ENT surgeons do facial fractures. And there's also oromaxillofacial surgeons. So like people that go to dental school and then do surgical training, the ones that do not just wisdom teeth, but a lot of them do facial fractures and big kind of what's called orthognathic surgery. If there's kind of jaw overgrowth or undergrowth, they can do bony changes of the craniofacial skeleton. But we learned to do a lot of facial fractures in practice, broken jaw, broken maxilla, and you try to do most of those through incisions in the mouth because you want to hide the scars as much as possible. Then there's a bunch of craniofacial deformities, cleft lips and palates being the ones that you're probably most familiar with. But there are all sorts of odd developmental things that can happen with the craniofacial skeleton. Some of the, if you learn anatomy at all, and you know that there's lots of different bones of the skull that are sort of fused with these things called sutures. Sometimes they, those don't fuse until much later in life to allow for the growth of the brain. Sometimes one or multiple of those sutures will fuse too early and will create a very significant defect of the skeleton of the skull, and can have problematic effects on brain development and things like that. So with neurosurgeons will be there to help kind of protect the brain, but plastic surgeons are kind of there to literally reshape the skull of a small child. It's nuts. And you want someone that's done a fellowship and that kind of stuff to be doing those type of procedures. So I don't do any things like that. And honestly, I think the cleft lips and palates, while I would be able to repair a lip like it is on the screen, there's so much care that's involved in clefts in terms of speech therapy, swallow evaluations, other things that are necessary. Those really should be done at a kind of all-encompassing center, which is why I don't do those procedures anymore. And there was a question about, are there any surgeries that you require people to get cleared from a psychiatrist before you perform surgery on them? The only ones that require, from my standpoint, that require psychiatric evaluation preoperatively are actually some of the gender confirmation surgeries. So that's actually a requirement for insurance to cover gender confirmation surgery. So if you're people with gender dysphoria that are transitioning from, and doing surgical correction of either what's called top surgery or bottom surgery, they need to have, there's a bunch of criteria that have been agreed upon both surgically and also insurance companies ask for it, about living as that gender for a while, having spent, having the diagnosis by psychiatrists, often having a set number of times on endocrine therapy first prior to going into surgical treatment of that option. That's really the only time that that they kind of need a psychiatrist to be involved. Back to craniofacial surgery, and the other things are kind of facial reconstruction after trauma and cancer. So this is an example of just someone that had a significant amount of craniofacial trauma. You can see that his arrows are pointing to a lot of the broken bones, but there's a break of the frontal bone, there's a break of the zygoma, which is sort of that cheekbone right here. And certain facial fractures, all fractures, whether it's on the hand or the bone or the arms or the face, some of them, if it's just broken but not out of line, you can just heal. And on the face, you can't really cast the face, so you just sort of let it heal. But if it's fractured and there's a likelihood that it's going to move, or if it's fractured and it's going to leave a permanent deformity, like for example, a punch here where that zygoma bone is fractured and it's going to leave a significant divot, you want to repair it, because you repair broken things to restore function, and the function of the face is kind of to look like a face. So fixing facial fractures doesn't always change how they're going to eat or smile or talk, but it does change how they're going to look. And that's one of the reasons that we would go ahead and fix that. And you can make, for a cheek fracture bone like this, a lot of times you can make an incision on the inside of the lip and in the mouth, sort of in the sulcus of the gums, and then get up down to the bone and put plates there, reduce everything and fix things that way. We're going to do a case here, and I don't know how well this will work with, I think there's a little bit of a delay between when the chats show up for us, but this was a 68-year-old female with a nasal lesion, you can see there, that was growing. I see stuff like this all of the time. And I'm gonna, if anyone has any thoughts about what they might do, feel free to type it in the chat. We'll see if that worked. Otherwise, we can just kind of go through the case. So this is kind of in the realm of craniofacial because it's on the facial, the facial part of the body. See, I'm clearly very good at anatomy. But we see stuff like this all the time, right? And while I'm not a dermatologist, we have overlap with multiple specialties, and dermatologists may be the ones that do full skin checks, but sometimes people come to me with saying, hey, I've had this spot on my nose for a really, really long time, or this spot on my body for a really, really long time. What do you think I should do? And there's lots and lots of common things that pop up on the body. Everyone that's probably listening can find 1 or 2 moles on their body, maybe many, many more. But if it's been there for a long time and then all of a sudden is changing, typically we want to get a sample of that to make sure it's not something worrisome, because benign moles can, with time, turn into something dangerous, specifically skin cancers. And so that's what you want to do if you see something that's changing, is that you recommend that you get a sample of it or you take a biopsy. Often you can take just a little kind of shave biopsy of the nose there, which is what we did in this case. And it turned out to be a melanoma. And melanomas are, so you can see here that where that area of the nose was is now sort of not, it looks almost a little bit light pink, not that dark color anymore, because a dermatologist had done a shave sample and it turned out to be a melanoma. And there are 3 types of skin cancers. There's a basal cell cancer, a squamous cell cancer, and a melanoma. Melanoma being the most worrisome because it has the potential to spread and can be a threat to your life. And so based on what that biopsy showed, that determines how you have to treat it. And so each type of skin cancer, based on depth and based on invasiveness, has a what's called a margin that needs to be taken around it. So you dot out kind of where the pigmented part of it was, but then you take additional tissue around it to make sure that you're getting any microscopic spread that could have happened to limit recurrence, and especially in melanoma, limit the chances that it can come back or cause a risk to your health. And for melanoma, the most common margin is 1 centimeter. And while 1 centimeter doesn't seem like a lot, if you dot out 1 centimeter from an area on the nose, which doesn't have a lot of extra real estate, all of a sudden you've got a really big hole in your nose. And so what I'll often do for these, because the nose can't just be like stitched back together when you've got a hole that big, is you plan for what you're going to do for your reconstruction at the time of the removal. And because the reconstruction is going to be a little bit more complicated, you don't want to start that process until you know that you have what's called clear margins. So you look at it under the microscope and make sure that everything is clear. For melanoma, that needs a special stains by a pathologist. It can't be done right at the same time. And so you actually remove it, make sure that it's all clear at the bottom and on the edges of it prior to going forward with the reconstruction. And I did this here by marking out the nose because I needed to make a template of what her nose looked like so that I could use that in the next stage for the reconstruction. And you can see all the drawings. You're like, what did he do? But plastic surgeons are crazy, and we think of anatomy a little bit differently than we even learned in medical school. And so we break down the nose, one nose, into 9 subunits, believe it or not. We got the dorsum, the paired nasal sidewalls, the paired nasal ala, the tip, the columella, and then 2 paired soft triangles. And so I marked out a lot of those subunits, and then the bigger circle, there's sort of a circle around a main dot that crosses all these other subunits. That's what I needed to remove. So a pretty big area. And then, so this is what she was left with afterwards. And with melanoma, you're supposed to go down through what's called the next kind of fascial layer. And so if melanoma is on the arm, you're supposed to go down to the level of those muscles of the arm. If it's on the nose or on the face, you're supposed to go down to the next sort of layer. So skin and all the fat above the next layer. So for this, you're supposed to go down all the way to the level of cartilage. And this was her afterwards. And again, the reason that she's, in my office here against a black curtain is because I needed to make sure that that pathology was cleared before doing the reconstruction. And so then you have to think, okay, what the heck do we do here? And I'll ramble for maybe a minute or so and see if anyone wants to type in some ideas of how the heck we're going to put this person back together. And a little clue is, do you think back to that thing called the reconstructive ladder that we talked about in the beginning? So you could let it heal. which is probably not going to look very good. That was that secondary intention. You could, what next up is primary closure. So can you stitch edge to edge? Probably not. If you mess around with your nose and you think, okay, I've got a hole that big, can I take one skin edge to one skin edge and then sew it together? No, there's just not really a lot of extra real estate. That big of a hole on the neck, no problem. You just pinch it together, close it with stitches, no issues. But so that's not going to work on the nose. Skin graft. Some people might have typed that in. Very reasonable option. Yeah, perfect timing right when I said that. Skin graft, great thought. And two reasons why you have to be a little bit worried about that. The one is that skin grafts don't really survive unless what you're putting it on has good blood supply. And so while there is some red tissues there, we probably could get it to work. Skin grafts don't work on bone or right on cartilage because the blood supply isn't enough to allow that skin graft to survive, right? A skin graft is you're taking something and putting it onto an area that's going to feed it until new blood vessels grow, because it doesn't have its own blood supply. So there's a chance that the skin graft wouldn't take. And there's a definite chance that even if it did take, it's just not going to look very good, because the skin, even a full thickness skin graft, if we took it from the neck, for example, the whole layer of skin and put it there, that's going to be a lot less thick than the piece of tissue that I removed. And this looks like it's kind of flush with the rest of the skin, but it's actually kind of a divot. But that was a great question. That was a great guess. So then moving up, okay, you can do those local tissue flaps. Like, is there anything nearby that you can do? And in smaller defects on the nose, yes, you can design little like semicircular flaps that sort of rotate in to fill smaller defects on the nose, but this one's definitely too big for that. Then we could do the Tagliacozzi flap, put her back in her nose on her arm. But that's kind of frowned upon because that went out of favor in about the 1600s. So we did a distant local flap, but of a different type. And then would a patient's age affect the viability of a skin graft? Not really. What affects the viability of a skin graft is technique, and also making sure that the recipient bed, the place that you're putting that graft, is healthy enough to feed that graft in the beginning, because it basically relies on the first couple of days on like diffusion. So oxygen and glucose has to be able to diffuse from the bed where you're putting the graft to the thin little graft here. So as long as it can survive from that, after about 3 to 5 days, it then is kind of stuck down and starting to grow little blood vessel attachments to its new site. But age is not really a limiting factor to that. So you're gonna probably be very surprised at what we ended up doing. You're gonna think that I'm nuts, but we did something called a forehead flap. So again, you can see that big defect there on the nose. You can see the cartilage at the bottom, that white part. That's the part that for sure would not have taken a skin graft. But we got a big old hole to fix. And so we are going to do a different type of distal flap. And some people are probably maybe starting to piece together the fact that what's down on her nose looks kind of similar to the shape of what's up on her forehead. And that was that template that I had used from before, and I kept and sterilized for this second part of the procedure. The thing that's coming up from her eyebrow and that little line in the middle is something called the supratrochlear artery. That's going to be the blood supply to this flap. So that's the thing that's going to keep this flap alive while we bring it back down to the nose. And this is actually the most common use of significant nasal defects that's still used today, based on techniques from hundreds and hundreds of years ago, called the forehead flap. So because the forehead heals incredibly well, and because it's actually more mobile than you think, you can borrow forehead skin, which typically has a same thickness, a similar color, quality, and texture to the other parts of the skin. We use this, and so you can actually elevate this whole thing that I've drawn up on its blood supply, and then flip it down to the nose like this and attach it. And if you remember back what we talked about with the old school Tagliacozzi flap, after about 2 to 3 weeks, that flap then grows new blood vessel connections to the area that you put it. And so what we do, no joke, is we do that, as we flip that down like this, and we cover up that defect. And you tell people, you spend a lot of time beforehand explaining to them that you're going to look pretty silly for about 2 months, because this is done almost always in 3 stages. The first stage um, is you flip it down like this. Second stage, I normally lift it up, thin the flap so it's a little bit more perfectly contoured, and put it back down. And then the third stage is that you cut at the top and you remove sort of the elephant trunk. So this is the first stage. It's not supposed to look perfect yet. We're setting the stage for the future reconstruction. You can see that up and down the forehead, it looks like a crazy scar, but you'll be, I think, pretty surprised at how well that ends up healing. This is it from the side, and I recognize again that this looks absurd, but you can also see why, even at this first stage, before I've done any of the thinning, that the nasal shape is actually looking pretty good. And that's most of her forehead thickness. And you can see that why a skin graft alone would have created a significant kind of concavity, and it would have looked like an odd sort of patchwork quilt type effect. And this is her a couple weeks later. And you can see that despite looking like this, there still is the ability to smile. And then what happens, like I said, is you do a couple more stages and then you can thin it down. And this was after her last thinning procedure, where you can see, that looks like a nose again. And if you look closely, you can see that only about half of that circular portion around the nose was there. And this is because this was a thinning procedure after that kind of connection point had already been removed. And now it's got pretty nice shape. And so it is this is an extreme example of something that might have to be done for a skin cancer, but that's one of the things that's super fun about what I do, is that even the surgeons that do a lot of skin cancer, sometimes for these type of things, they will send them to me, because it's just kind of where that creativity and stuff comes into. So it's very satisfying to be able to take someone from a scary thing to a big hole in their nose that really freaks them out and they're wondering how it's going to be possible, to this crazy idea that they're like, what are you talking about with that suggestion, to then all of a sudden they have a nose that you really can't tell anything can happen unless you're looking super, super closely. So that's a little bit about craniofacial surgery. Here's a nice disgusting picture for your morning. Hand surgery is another common thing that people don't know that plastic surgeons do. I get a lot of people that come into my office for carpal tunnels and other things and are very confused why they're in a plastic surgeon's office and why there are pamphlets of, tummy tucks and stuff in the waiting room. But common things in hand surgery that I do are kind of things: carpal tunnel, cubital tunnel, so compressions of nerves that are causing numbness and tingling, lots of trauma. So there are hand fractures, finger fractures, metacarpal fractures here, nerve and tendon transections. So you're cutting something, avocado knife or something like that, Perry knife, and you cut both tendons of the finger, or you cut your digital nerve. I can fix that. Soft tissue damage, those type of things. A lot of arthritis. So base of the thumb, there's a bone called the trapezium that starts to rub on the thumb metacarpal. You can do surgery for that to really improve. And you get crazy infections. This picture here was in my first year of practice, the worst hand infection I had ever seen. That the only time I've ever had to remove an entire hand, because every single structure in his hand, including all nerves, most blood vessels, and almost every muscle and tendon, was covered in pus. And he was a very unhealthy gentleman. And this was like one of the first cases that I did at this hospital, and everyone thought I was nuts. I'm like, this is the only option that this person has. So that's a rare example. But hand surgery is very, very fun because the anatomy is phenomenal. You get to sit down when you operate. That's cool. And so here's a case, a kind of a thing that hand surgeons, especially fellowship trained hand surgeons, would do. So this was a 38-year-old guy, construction worker, had a severe, something crazy heavy dropped on his thumb. And it was basically an amputation. It was hanging on by like a little skin bridge. And what you do in these cases, anytime you can see, if you look, that the skin, the color of the thumb is a little bit different than the color of his hand. And that's because there's very poor blood flow to it. So he's completely transected one of the arterial supplies to the thumb. It's hanging on by just a little bit of blood from the skin that's connected, but that thing's not going to survive just by stitching it up. So these are called replantation, where a thumb or a finger has been amputated and then needs to get put back together. And so you bring this patient to the operating room, and under a microscope, you can find those really teeny little blood vessels. They're often like 1 or 2 millimeters, and you hook them back under a microscope. You can then fix the bones or any fractures that there are. You can fix any tendons that have been cut as well. And then you can put these pins in there to sort of keep it in a straight position. So that's called a revascularization or a replantation if it's all the way off. Those get done at kind of specialty centers in the Bay Area. There's really 2 places. Unfortunately, I have to train at both of them. So one with Stanford. I think UCSF might have a program too for it. And then there's a private group called the Bunky Clinic that does a lot of this type of stuff. Someone asked, what caused the infection on the previous slide? When would patients see an orthosurgeon versus a plastic surgeon for hand surgery? Two great questions. The infection was someone who had wildly uncontrolled diabetes. So an A1C, I believe, of like 16, which if anyone that's done some shadowing in primary care knows that that's crazy high. It's supposed to be like 5. And he just gotten 2 cuts on his fingers from like a blender, cleaning a blender, but had ignored it for a week. And sometimes when you have diabetes that bad, you have such dense numbness of your whole fingertip and sometimes your whole hand that you can't even really tell, and you just ignore it. There's like a lot of denial. So by the time he finally came to the hospital, that infection had spread from here. 2 of his fingers were black, but inside his hand and all the way up to around here was pus, and it started to eat away at everything. The next question was, when would patients see an orthosurgeon versus a plastic surgeon for hand surgery? Great question. It just depends on the situation. So because I did so much hand during my training, basically every rotation that I did had some hand surgery as part of it. So I felt very comfortable with the bread and butter. And so for my group, I said, hey, I do a lot of hand surgery and I'm happy to see anyone. And there's a couple of things that I won't do. Certain like complex wrist arthritis that I just didn't do a lot of, or like wrist ligament tears that need scopes and stuff. I just wasn't trained in those. But a plastic surgeon that did a hand fellowship might feel comfortable in those. And there are certain orthosurgeons that did hand surgery and training, but just want to do knees and hips now and don't do any hands. So actually in our group, none of the orthopedics want to do hand. They all come to me. So it really just depends on the situation and who the surgeons are available in the group that feel comfortable. I'd say maybe less than 5% of cases that come my way that are referred to me for hand do I send elsewhere to like a pure solo hand specialist, because most of it is stuff that I can handle and do a very nice job. Another thing that sometimes happens is if for example, I don't think it was this case, I think this was a separate one, but sometimes if it's been such a bad crush injury that all of those vessels to the thumb or the finger were damaged, that you put them back together, but that doesn't work, either it clots off or the finger dies or they come too late, then sometimes it doesn't work. And in certain fingers, it's not that big of a deal because it's so functional, but missing your thumb really is a big deal. And I'm gonna see if anyone wants to type in suggestions about what you might do in this situation. Sorry, just making sure that my clinic isn't, okay. So this is someone that wasn't able to, you can see that they'd had a scar. I think they tried to salvage the thumb, but it wasn't successful. That's probably why they have the scar there. And so then you can kind of go back to reconstructive ladder again. Can you do, there's nothing to heal. It's already healed. There's no skin graft that's going to work. You could add soft tissue from somewhere, which we'll actually show you a picture of in a second. Nothing local. And this kind of gets to that very top of the ladder. So bringing in a free tissue transfer for somewhere else. And, oh, cool, big toe, prosthesis. So prosthetic is a great option. They're not great. They're static prosthetics, and they're mostly cosmetic. So there are things that you can do to create a appearance. That's most common if you have a partial finger amputation, like maybe at the middle. They have pretty realistic prosthetics that go on top. They're not super functional, but they can be nice for events and things like that if you want to feel comfortable and less self-conscious. So great thought. And awesome. So big toe or a toe, they said, maybe not big toe, so balance is not thrown off. So absolutely, it's a great toe transfer, or sometimes a second toe transfer. It really depends on the size of the toe. Believe it or not, using the big toe, you're surprisingly functional in terms of balance and what you're able to do. And the little bit that you lose on the foot is worth the gaining of function, because the thumb is responsible for what they estimate like 80% of hand function. But yes, you can bring in a toe and bring it onto the hand, and you can bring that toe along with a length of bone that's needed, the tendons on each side, and hook it up to the recipient tendon so that you can flex and extend, because a thumb that's just sitting there isn't very helpful. You can bring in the nerves and hook them up to the nerves so they actually have sensation, and it feels like it's from the thumb because it's going back on the nerves that go to the brain that says that's my thumb. And so this is an example of doing that. Oh, actually, no, this is a quick example of something called a groin flap that you can do in situations where you've lost most of the soft tissue, but you still have like the bone. So there are sometimes these things called degloving injuries where all of the skin has been ripped off, but you still have bone, maybe some tendons, and you can't in the meantime, just put like a skin graft around it because it's surrounding bone and surrounding tendons, but you don't want to take the whole thumb off because you have some structures that you can use. So this is something that's done not very commonly, but it's called a groin flap. You actually lift up a little piece of skin from the groin, you stick your hand into it and you wrap it around the thumb, and then a few weeks later you disconnect from the groin. Similar again to that flap here. This is not super common because of microsurgery, but it's just an interesting example. But this is what you can do. You can do big toe or small toe. I think this patient we had discussed about the differences between the big and the second. The big was pretty big, but the small toe was probably not going to be weak enough for him to go back to his construction job. So we decided to go with big toe. And here we're marking out all of the anatomy, where the nerves should be, where the tendons are, where the joint is, where the artery and the vein are going to be, where an extra vein that you might use for venous outflow is going to be. And this is a very cool picture of that all connected. So that toe is still alive, believe it or not, because it's connected from its artery and its vein onto the foot, despite us having removed everything. So we could leave it there for hours, and because there's blood going in and blood coming out, it would stay alive. But we've separated here the tendon on the top, the tendon on the bottom, the two nerves that are going to be attached to the recipient nerves to help you feel both sides of the new thumb. And then we don't disconnect the artery and the vein until the very end, when we're then going to hook it up under the microscope. And then you find the corollary structures on the hand to hook everything up. So you do that, you fix the bone, you put that back together, you put the tendons back together, you repair those, you put the nerves back together under a microscope, you attach the vein under a microscope, you attach the artery under a microscope, and then you've got a functional thumb. And again, this one was pretty big, but it was better for him than the second toe because of what he was going to do. There are debulking procedures that you can end up doing. This was on the table, so it's already a little bit swollen. But in certain situations, they ends up working pretty darn well, to the point where if you shake people's hands, and unless you're looking or they're showing you, you probably wouldn't know. And these things heal to the point where you can bend, you can extend, you've got strength, you can feel it. And it's a pretty cool option for a thumb that has been amputated that wasn't able to be saved at the same time. The last fellowship that you can do is microsurgery. So we talked a little bit about this. That's kind of the top of the reconstructive ladder. They've changed that term to someone called it the reconstructive elevator, because you can get on and off at your choice. And it's because microsurgery has become not this crazy rare technique anymore, but it's something that people like myself who didn't even do a fellowship in it because we did so much of it at Stanford can do as well. And so basically any block of tissue that can survive on a single blood vessel, on artery and vein, you can take off from that area and put anywhere else, anywhere. So we typically do things that need reconstruction, but I mean, I theoretically could take off your fibula from your leg bone, have it attached to some skin around it and an artery and vein, attach it to like your superficial temporal artery, and make you a unicorn if you want. It's like you can do that. I'm not going to, but that is something you can do. All you need is an artery and a vein and a block of tissue that's going to survive on that transfer. And so this was my mentor, one of my mentors at Stanford, and this is us under the scope together, I think in the last year of training. But it's fun because you can take these stitches that are smaller than your hair and sew together very teeny blood vessels and make things alive. And so the blocks of tissue that you will often do is skin and fat to kind of cover holes or create shapes from somewhere. You can bring muscles to places, so big like orthopedic injuries, motorcycle accidents that have huge exposed bone and hardware. You can't just let that heal. You need to make sure that hardware doesn't get infected. You can bring muscle in there to cover that wound. You can transfer bone to places. We'll often reconstruct the jaw after cancer with that fibula bone like I talked about. You can bring muscle with a nerve so that it's a functional muscle transfer. There are certain kids that are born with hemifacial paralysis, so the facial nerve doesn't work and certain facial muscles don't work. So you can actually bring in a small muscle from the leg, bring it into the face, attach it to the nerve of their face so that when they sort of bite down, they can actually have a symmetric smile again. People that have lost biceps function or have a significant brachial plexus injury, you can create a thing that crosses the joint and you attach it to a nerve so that it actually fires and bends the elbow, whereas before they were pretty much paralyzed there. So it's really cool stuff. And the most common microsurgery that I do is actually for breast cancer. So this was someone that had a mastectomy and didn't have a reconstruction in the beginning, but you can see between the two pictures that there's a little bit less tummy fluff. So you can actually take the tummy, the skin and fat from a tummy tuck, but instead of just taking it off and throwing it away, you can take it on its blood vessel connections as they come up through the ab muscles, and then hook it up to blood vessels in the chest and make a breast out of the soft, squishy skin and fat from down below. And basically they get a free tummy tuck from insurance. They get a soft, squishy breast without an implant. And then you can even make a little nipple and tattoo it, so it looks pretty good afterwards. So that's kind of the most common microsurgical reconstruction that I do. We are coming up, well, this went pretty fast, and I will extend maybe the next 5 minutes for a couple of questions. This was super fun. I hope that it was interesting for you. I can't see anyone's faces, so maybe this was super boring and it was just me like fanboying out about my specialty, but this was a blast. And this was funny. This is a buddy of mine who said that photo from the Web Shadowers session said that I looked like I was about to become a Batman villain after some corrupt businessman steals your idea for profit. So as you can see, I take myself very, very seriously. But this was a blast, and we can do questions for maybe 5-10 minutes or so. What does your average day at work look like? Great question. So let me see. Let me pull out my schedule. I'll tell you exactly what I am going to do today. This will be it's a good mix of clinic and operating rooms. So today I have a pre-op for a augmentation, kind of a mommy makeover, so some cosmetic surgery. I have a hand injury, so someone that crushed their finger. I have a pre-op for rhinoplasty. I have someone with something called Dupuytren's, which is a hand deformity that I'm going to fix. I'm going to inject some enzyme into there. I have someone who is post-op from a breast reconstruction for cancer. I have someone who had a big cancer of her chest that I helped do a surgical reconstruction on. I have, I'm taking off a fully formed accessory nipple, so you can have extra nipples on your breast. This is like a 30-year-old woman with two completely normal looking nipples, but on one breast. I have someone with something called trigger finger that I'm going to do in the office, in a hand surgery. I have a pre-op for her second stage breast reconstruction. There is a new breast cancer. There is another trigger finger, so some hand there, broken bone of the hand, a couple lipomas. So if anyone's seen Dr. Pimple Popper, all of those like cysts and lipomas, I do those too in the office because it's easy. I have a post-op breast lift. I have a consultation for liposuction, and I have skin cancer of the cheek. So that's part of the day. It's a shorter day today. Let's see. Everyone is, oh, nice. Everyone is loving this presentation and wants you to come back. That's great. I would love to. This has been super fun. And I mean, I've got hundreds of cases that we could go through. So if this has been something that people have enjoyed, I'd be happy to do it because I love this kind of stuff. Do skin grafts heal faster for younger people than older people due to the skin cells turning over faster in younger ages? Great question. Not really, because the skin cells are going to turn over, but that's not what we're relying on for the transfer of a graft. Those skin cells, like the very top layer of the epidermis is what turns over, but the lower layers within the dermis itself doesn't. So a skin graft heals pretty similarly between the two. So very good question though. And then let's see, could you talk about your residency program, like structure of it in comparison to doing general surgery first? So my residency program for plastics when it was 6 years was the first year or two is a lot of general surgery, just because you get surgical experience, you learn about patient management. You have a couple of rotations on plastics, but not a ton. And then from third, fourth, fifth, and sixth year, it's all plastic surgery. And you rotate to different sites. So we're at Stanford, we're at the VA hospital, we go up to San Francisco to the microsurgery group, we go to the county hospital a bunch of times, and we go to Kaiser system. So it's through all those systems that you get different types of things. So at Stanford, you do like the really biggest of the craziest complex cases. At Kaiser, you do a lot of the bread and butter stuff, which is a great learning experience for someone like myself who's going to do a lot of that in their practice. And it's kind of all over the place. So most residency programs at this point are what we call combined or integrated, so that you do it right out of medical school and you get kind of all that training at once. You mentioned that both you and your wife work in the medical field, especially considering that you were a surgeon. How do you maintain a good work-life balance with the family? That is an awesome question. And one of the reasons that we started that podcast together, my wife is way cooler and way more inspiring than me, and is a lot more active on social media and stuff. And so her name is Dr. Renee Paro, R-E-N-E-E. And you should look her up on Instagram, because I look at her every day and I'm like, holy shit, you are the most incredible person I've ever met. And that's one of the reasons that we started the podcast together, was to sort of talk about how we approach all of these things, right? And we called it Reconciling Medicine because, there's a thing called the medical reconciliation when you're in like your electronic medical record, where people have all these lists of medicines, and you're supposed to go through time and like take some of them off that they're not on anymore, make sure that it's actually up to date. And that's kind of what we feel like we're supposed to do with medicine. You got to like take stock every once in a while and be like, what's working, what's not, and you got to shift that. And so finding a way to do all the things that we want to do, my biggest fear in training was that I was going to be like a mediocre surgeon, a mediocre husband, and like a mediocre dad. And I don't think that has been the case. I think that I've managed to be quite good at all of them, but it takes a lot of work, and you got to just constantly work at it. And another plug is just, it's so hard to fit a lot of information into 1 hour. And that's one of the cool things about the podcast, is that each episode is about 45 minutes to an hour or so. And we talk about so many topics. So again, if anyone's interested in that, check it out, because we go through a lot of these things in a lot more detail. And unfortunately, it's 9 o'clock. I have patients to go see. And this was a blast, everyone. And thank you so much for the comments. And hopefully this was entertaining. And I'll speak with the Web Shatterers people and see if we can set something up again in the future. So thanks a lot.
Thank you so much, Dr. Paro. This was an amazing presentation. It was incredible, honestly.
Oh, awesome.
We all appreciate you taking the time to do this so much.
My pleasure. It was an absolute blast.
Additionally, thank you everyone who attended. The link to the Google form has been posted in the comments and will be posted in our Instagram bio shortly. If you please fill it out within the next 30 minutes, we'll be able to verify your attendance. Thank you so much again, everyone.